Hello students, good day to all of you. So today we are going to discuss about the dorsum of foot and the retinacula of the foot. So in the previous session I have discussed about the anterior and the lateral compartment of the leg. So from the anterior compartment and the lateral compartment, if you descend downwards, then actually it continues as the dorsum of foot. So today session, our learning objectives is going to be about the cutaneous innervation. So that is the sensory nerve supply to the skin of the dorsum of foot, then the dorsal venous arch, which is responsible for the formation of the two great veins, that is the great saphenous vein and the small saphenous vein, both the superficial veins. Then we are going to discuss about the retinacula of the foot, especially the extensor retinacula. Then the only muscle which is present on the dorsum of foot is the extensor digitorum muscle. And finally in the dorsum of foot I will be discussing about a very important structure, which is the Dorsalis Pedis artery. Now we will just quickly review the skeleton of the dorsum, that is the bones of the dorsum of foot. So here now you are able to see the dorsum of foot, mainly the bones from above or superior view. The tarsal bones you are able to see here. So this is actually the talus bone for you. The talus, the upper surface, is actually called as the trochlear surface of the talus, which is going to articulate with the inferior surface of the tibia and forming the ankle joint. And even on the either sides you also have the facets for the medial malleolus, medially of the tibia, and lateral malleolus. Then in the front what you see is the head of the talus. Between the head and the trochlear surface you have a small constriction which is actually called as the neck of the talus. The head articulates anteriorly with the navicular bone. You are able to see it is articulating with the navicular bone. Then behind what you see is the calcaneum. So that is the posterior surface of the calcaneum which forms the heel. And calcaneum anteriorly articulates with the cuboid and superiorly it articulates with the talus, and there is a groove between that which is actually called as the sinus tarsi. Then more anteriorly you see the three cuneiforms, the medial, intermediate and the lateral cuneiforms, and the lateral bone is actually the cuboid. So 7 tarsal bones you are seeing: talus, calcaneum, navicular, 3 cuneiforms and then the cuboid bone. So talus forms with the tibia and the malleolus of tibia and fibula to form the ankle joint. Below the talus articulation, this is actually called as the subtalar joint. Okay, the subtalar and then mid-tarsal joints. Those joints actually are responsible for bringing about your inversion and eversion movement, whereas the ankle joint is responsible for the dorsiflexion and the plantar flexion movement. Then you have the metatarsals, first, second, third, fourth and fifth metatarsals. The first one is the shortest and the stout. So it has got head at one end and base because they are all miniature long bones. Then you have the phalanges. First digit has only the proximal and distal phalanx. The lateral 4 digits has the proximal, middle and distal phalanx. This joint between the metatarsal and the phalanx is actually called as the metatarsophalangeal joints, and these are all the interphalangeal joints. So next to the skeleton, we are going to have a quick look about the skin of the dorsum of foot, then followed by what is present deep to the skin. You all know that deep to the skin is the superficial fascia. The superficial fascia contains a variable amount of fat, but in case of dorsum of foot, the fat is very minimal. Okay, very minimal amount of fat as compared to the other parts of the body. So in the superficial fascia, you come across superficial veins and the dorsal venous arch, cutaneous nerves, and the lymphatics, which is draining the skin of the dorsum of the foot. So here a picture of the dorsum of the foot, and here we will try to actually appreciate some of the structures on the surface anatomy. The skin is a hairy skin, you are able to see here, and below the skin definitely you are able to see the tendons, followed by that you are able to see that is the dorsal venous arch, which is lying along the base of the metatarsals. Okay, a subcutaneous structure, and medially it is continuing as the great saphenous vein after joining the medial marginal vein. So that is also very clearly and beautifully seen here. Same way the lateral marginal vein and will join, and it will form the small saphenous vein. So these tendons you are able to see here. The medial one is the tendon of extensor hallucis longus, and these are the lateral 4 tendons of the extensor digitorum longus. Extensor digitorum longus muscle tendons you are able to see here. Okay, then here interdigital spaces or clefts, first, second, third and fourth clefts. Okay, so here these clefts are present, and in the cleft you will be also able to appreciate the dorsal interossei muscles. Okay, so 4 dorsal interossei also can be seen on the dorsum of foot. So these are the digits, and the nail bed you are able to see here. So they are actually present at the region of the distal phalanx. Okay, so this is the distal phalanx region. Here you are able to see the medial malleolus. This projection is the medial malleolus, and here you will be able to see the lateral malleolus, medial malleolus and lateral malleolus. This I told you is actually the dorsal venous arch, and from that sometimes you will be also able to see the impressions of dorsal metatarsal veins. Then one more artery you can palpate here on the surface between the tendon of extensor hallucis longus and the first tendon of digitorum longus, the Dorsalis Pedis artery. Okay, a very important artery, the Dorsalis Pedis artery, you will be able to see here. Now coming to the innervation of the dorsum of foot. So medial side of the leg and medial border of foot up to the ball of the great toe is actually supplied. Cutaneous innervation is supplied by the saphenous nerve, which is a branch from the posterior division of the femoral nerve. Same way, when we finish the medial border, coming to the lateral border of the foot along with the little toe, but excluding the distal phalanx region, skin over the distal phalanx region, you exclude. The remaining part is actually supplied by the sural nerve. Okay, so that is about the sural nerve, which is a branch of tibial nerve. Sural nerve supplies. The remaining part, lower lateral part of the leg and the remaining dorsum of foot is actually supplied by the superficial peroneal nerve, which is a component of the common peroneal nerve. Superficial peroneal nerve supplies except the first dorsal interdigital space which is supplied by the deep peroneal nerve. So the deep peroneal nerve, especially the medial terminal branch of the deep peroneal nerve, supplies this first dorsal interdigital cleft. Okay, so four sets of nerve you should remember: saphenous nerve, sural nerve, superficial peroneal nerve, and deep peroneal nerve. Whereas the region of the distal phalanx, the skin over the region of distal phalanx, medial 3½ is actually supplied by the medial plantar nerve, and the lateral 1½ is actually supplied by the lateral plantar nerve, which are actually the terminal branches of the tibial nerve. Okay, medial plantar nerve and the lateral plantar nerve. Now you might wonder why so much of importance is actually given to the cutaneous innervation. That is because when you test for the sensations, then you can know if the sensation is affected or not based on that which spinal segment is affected. So for that you should have a fair idea about the root value of these nerves also. Okay. So mainly, as I told you, to revise once again, superficial peroneal nerve, major part of the dorsum except the first dorsal interdigital cleft, which is by the deep peroneal nerve, medial border by saphenous nerve, and lateral border by the sural nerve. Skin over the distal phalanx, lateral 1½ is by lateral plantar, and medial 3½ is by the medial plantar nerve. Next, the most superficial structure you come across in the dorsum of foot, in the superficial fascia, is the dorsal venous arch, which is lying convexly. The convexity is towards anterior, is the dorsal venous arch along the head of the metatarsals. The dorsal venous arch is formed by receiving 4 dorsal metatarsal veins. Okay, the dorsal 4 metatarsal veins, they join to form the dorsal venous arch, and mediality is joined by the medial marginal vein, which is coming from the medial side of the great toe, and then it forms the great saphenous vein, which passes in front of the medial malleolus. The lateral part of the dorsal venous arch is joined by the lateral marginal vein, which is from the lateral side of the little toe, and after joining this, it continues as the small saphenous vein, which passes behind the lateral malleolus. Okay, which passes behind the lateral malleolus. Okay, then if you look at it from the concavity of the arch, you can see it is continuous with the anterior leg vein. It is actually continuous with the anterior leg vein. So that is about the dorsal venous arch. Okay. Now, before going to the deep fascia, we will also try to have a look about the lymphatics. So the lymphatics along the medial side of the foot and from the great toe will follow the course of the great saphenous vein and enter into the vertical group of inguinal lymph nodes. Whereas from the lateral side, what happens is it will follow the small saphenous vein and enter into the popliteal lymph nodes. Okay, so lateral part of foot and little toe along the lymphatics follow the course of the small saphenous vein and drain into popliteal lymph nodes. Along the medial border of foot and great toe follow the great saphenous vein and they will drain into the superficial inguinal nodes, vertical set of superficial inguinal nodes. Superficial inguinal nodes is also important, so kindly have a fair idea of it. Don't omit. Sometimes it is very usually asked in the examinations. So the deep fascia is not very thick, somewhat thin, but only thickened at certain points to form the retinaculum. So especially in the dorsum of foot, you are able to see the inferior extensor retinaculum. And if you trace it medially or laterally, it merges with the plantar fascia. Okay. So at the sides it is merging with the plantar, that is the plantar aponeurosis, which is the expanded tendon of plantaris muscle. Okay, so modification of deep fascia in the foot, mainly the retinacula. It forms the retinacula, the inferior extensor retinacula. Then, of course, you are able to see the tendons. You are able to see the tibialis anterior with its synovial sheath, extensor hallucis longus with its synovial sheath, digitorum longus and peroneus tertius with its common synovial sheath. Then the tendons are exposed here. The only muscle in the dorsum of foot you are able to see here is the extensor hallucis brevis and the extensor digitorum brevis. Intrinsic muscle. Here you are able to see the dorsal interossei between the interdigital spaces. Dorsal interossei. 4 dorsal interossei you are able to see here. Then you are able to see more laterally the peroneus longus muscle. So as I told you, the tendons of the tibialis anterior, extensor hallucis longus, extensor digitorum longus and peroneus tertius. Intrinsic muscles, extensor digitorum longus, extensor digitorum brevis is the muscle. Arises from the anterior part of the upper part of the calcaneum and from the stem of the inferior extensor retinaculum. Then it gives rise to 4 tendons. The medial most tendon is actually called as the extensor hallucis brevis, and the lateral 3 tendons are actually called as the extensor digitorum brevis. Extensor hallucis brevis gets inserted into the base of the proximal phalanx of the great toe. Okay. So it is inserting into the great toe, whereas this lateral 3 tendons, they join with the tendons of extensor digitorum longus to form the dorsal digital expansion. Okay, and then through the dorsal digital expansion, it gets inserted into the central tendon will go to the base of the middle phalanx, and the 2 collaterals will go to the distal phalanx. Okay, only intrinsic muscle is the extensor digitorum brevis, and the medial most tendon is actually called as the extensor hallucis brevis, and this actually crosses the dorsalis pedis artery. And of course, your deep peroneal nerve from lateral to medial. The tendon crosses the dorsalis pedis artery from lateral to medial side. So what is the action of this extensor digitorum brevis? Dorsiflexion of the toes, especially while taking off during running and walking. Okay, when taking off, your foot is dorsiflexion. So mainly it dorsiflexes the toes when the ankle is dorsiflexed. Extensor digitorum brevis action you can appreciate. You dorsiflex your ankle joint and then you dorsiflex your toes. Okay. So next, coming to the dorsalis pedis artery, it is actually the artery which is present on the dorsum of foot, continuation of the anterior tibial artery. And then what happens? Actually it ends at the first dorsal interdigital cleft, up to first dorsal interdigital cleft, and then passes to the sole of foot and completes the plantar arch. Okay, passes between the 2 heads of dorsal interossei in the first dorsal interdigital cleft, goes to the sole of foot and completes the plantar arch, which is actually formed by the lateral plantar artery. So thereby it is completing the plantar arch. Okay, so that is the extent of the dorsalis pedis artery. So if you want to mark the dorsalis pedis artery on the surface, you take a point, midpoint between the medial and the lateral malleolus, the 2 malleolus, you take a point and you put a point on the first dorsal interdigital cleft between the great toe and the first toe, and you join these 2 points. That will represent the Dorsalis Pedis artery on the surface. So the artery lies posteriorly over the ankle joint, navicular bone, and the intermediate cuneiform bone. It lies successively on top of these. And anteriorly it will be covered by the skin, superficial fascia, the deep fascia, and the tendon of extensor hallucis brevis. Okay. So it will be covered by skin, superficial fascia, and the tendon of extensor hallucis brevis crosses, and it is also overlapped anteriorly by the inferior extensor retinaculum. Okay. So that is the Dorsalis Pedis artery for you, and laterally accompanying is the deep peroneal nerve. So that is the deep peroneal nerve. This is your extensor hallucis brevis tendon and extensor digitorum brevis tendon, which is joining your extensor digitorum longus tendon. The next coming to the relations of the Dorsalis Pedis artery. So medially it is related to the tendon of extensor hallucis longus, and laterally to the first tendon of extensor digitorum longus, tendon for the second toe, and also laterally very intimately it is related to the deep peroneal nerve. So the deep peroneal nerve above also it is related laterally to the anterior tibial artery. The same laterality or relation it is actually maintaining even in the foot. So it is not crossing anywhere. Just in the lower part it actually comes anterior to the artery, but then again it maintains its lateral position. So that is the relations of the Dorsalis Pedis artery. Now actually coming to the branches of the Dorsalis Pedis artery. So mainly you are able to see here lateral tarsal artery. Then you will see the medial tarsal arteries. Then you see the arcuate artery, and then first dorsal metatarsal artery. So first dorsal metatarsal arteries. So these are mainly the 4 branches: lateral tarsal, medial tarsal, arcuate artery, and first dorsal metatarsal arteries. Lateral tarsal artery takes part in the lateral malleolar network. Okay, an arterial anastomosis around the lateral malleolus. Medial tarsal artery takes part in the medial malleolar network. Then you see the arcuate artery. It is called as arcuate because it is actually like an arch, again which is lying opposite the base of the metatarsals. Okay, it mainly gives dorsal metatarsal arteries, second, third, and fourth dorsal metatarsal arteries, and finally anastomosis with the branches of the lateral plantar artery. So it gives mainly the dorsal metatarsal arteries. These dorsal metatarsal arteries will again divide into the dorsal digital arteries, adjacent sides. It gives rise to the dorsal digital arteries. Then these dorsal metatarsal arteries through the proximal perforating arteries will maintain its connection with the plantar arch, which is present on the sole of the foot, through the proximal perforating arteries. It also has a distal perforating arteries through which it will connect with the plantar metatarsal arteries. Okay, proximal perforating and distal perforating. Proximal perforating connects these dorsal metatarsal arteries with the plantar arch. Distal perforating arteries connect the dorsal metatarsal arteries with the plantar metatarsal arteries. Okay, so that is about the branches of the Dorsalis Pedis arteries. Arcuate artery, first dorsal metatarsal arteries, medial tarsal artery, and the lateral tarsal artery. So first dorsal metatarsal artery from the dorsalis pedis directly before it terminates or passes to the sole of the foot to join the plantar arch. Just prior to that, it gives the first dorsal metatarsal arteries that will actually divide into dorsal digital arteries to supply the adjacent sides of the first and second toe, and it will also give a branch to the medial side of the great toe. Okay, so adjacent sides of first and second toe, and also gives a branch to the medial side of the great toe. So that is about the first dorsal metatarsal artery. So mainly you are able to see here the dorsalis pedis artery is mainly used for peripheral pulse recordings, palpated for its peripheral pulse, and you should look between the tendon of extensor hallucis longus and extensor digitorum longus. So peripheral pulse can be recorded, and very important thing is it is absent congenitally in 14% of the people. So that you should also keep in mind. Sometimes if the peripheral pulse is absent, it might also be due to the absence of this artery. So one of the arteries chosen for peripheral arterial pulse, like your radial artery. Thromboangiitis obliterans or Buerger's disease is actually inflammation of these arteries and veins. So it is a disease affecting the inflammation of arteries and veins, which also commonly affects these arteries. Now what happens is, when the arteries get inflamed, then naturally blood clots will be formed. It will actually interfere with the blood supply, and you might find the skin turning bluish to black, and then finally gangrene will be formed. This is most commonly seen in people who smoke, not only smoking but also using other forms of tobacco. Okay, so then naturally what happens is, because there is no arterial supply, gangrene will be formed, and if not treated and if the tobacco usage is not stopped, then the gangrene will proceed and we have to go for amputation. Usually Buerger's disease starts in the foot or hand and it proceeds to the greater part of the arms and legs. Now apart from the usage of tobacco, it might also be due to some idiopathic reasons. It might also be due to congenitally, genetic predisposition also cannot be completely disregarded, and it is also found there is association between this Buerger's disease and recurrent infection of your gums. But what is the association? It is still not clear, but people whose gums are infected, they have a greater chance of this Buerger's disease. Okay, so pain will be there when you try to use this foot, and the pain subsides when the foot is at rest. That is called as intermittent claudication. Then what happens is, around the artery the skin will become pale, which is actually called as the Raynaud's phenomenon. So that is about the applied anatomy for the blood vessel. So with this we will see the medial malleolar network. So the lateral malleolar network first. The lateral malleolar network is formed by the lateral tarsal artery, then branch from the arcuate artery, then branch from the lateral plantar artery. Okay, so lateral tarsal artery, arcuate artery, lateral malleolar branch of the anterior tibial, and also the lateral plantar artery. So and also from the perforating branches of the peroneal arteries. So they all form the lateral malleolar network. Medial malleolar network is mainly from the medial tarsal artery. Same way, medial malleolar branch of anterior tibial artery. Okay, and then medial plantar artery, and finally by malleolar branch and calcaneal branch of the posterior tibial arteries. So both sides, there it is lateral tarsal, here it is medial tarsal. Anterior tibial gives both medial malleolar branch to the medial malleolar network and lateral malleolar branch. Here it is medial plantar artery, there it is actually lateral plantar artery. Laterally, one more extra artery is the arcuate artery. Then posterior tibial artery, here it is malleolar and calcaneal branch, there it will give perforating branches. So we have finished with the structures on the dorsum of foot. Now actually we will discuss about the retinacula of the foot. So coming to the retinacula of the foot, you all know that the retinacula of the foot is the modification of the deep fascia. It is actually the modification of the deep fascia or thickening of the deep fascia, mainly present around the ankle and the upper part of the foot. Now why actually the retinacula are present? To prevent the bowstringing of the tendons, bending of the tendons, especially when you move, because all the tendons from the leg when moving to the foot, they change their direction. So they are changing their direction. These tendons, even you are able to see the peroneus longus is going behind. So during any movement of the foot, because there is a change in direction, what happens? There is a tendency of these tendons to bow out medially, to bend medially. To prevent that, what happens is these retinacula firmly hold the tendons in its place. So in the front you have the, mainly in the foot you see the inferior extensor retinaculum, and the lower part of the leg you see the superior extensor retinaculum. Then laterally you see the superior and inferior peroneal retinaculum, and posteromedially you see the flexor retinaculum. So here you are able to see the superior extensor retinaculum, which is a modification of the deep fascia of the leg. Extends from the lower border, from the lower part of the anterior border of tibia to the anterior border of the fibula, lower part of the anterior border of the fibula. So that is the extension of the superior extensor retinaculum. It splits to enclose the tibialis anterior. Sometimes they tell the tibialis anterior pierces the superior extensor retinaculum, and you are able to see the tibialis anterior is within its synovial sheath. So structures passing from medial to lateral, it is going to be tibialis anterior followed by extensor hallucis longus. Then you have the anterior tibial vessels and deep peroneal nerve. Then you have the extensor digitorum longus, and most laterally the peroneus tertius. Okay. So these are the structures passing medial to lateral. Tibialis anterior, extensor hallucis longus, then vessels and nerves, then followed by extensor digitorum longus. The next retinaculum which is present in the foot, dorsum of foot, is the inferior extensor retinaculum. It is Y-shaped, it has got a stem, and it has got a upper arm and a lower arm. Okay. So the stem is actually attached to the calcaneum, anterior surface, upper part of the calcaneum. The fibers pass laterally and wind around the tendons of the peroneus tertius and extensor digitorum longus. Loop, they form a loop and then again come back to the calcaneum itself. Mainly the fibers from the stem, they loop around this extensor digitorum and peroneus tertius. This part. Then after splitting from the stem, the upper arm is actually going to attach to the medial malleolus, and the lower arm actually merges with the plantar aponeurosis. That is the attachment of the upper arm to the medial malleolus and the lower arm to the plantar aponeurosis. Okay. So structures passing deep to the inferior extensor retinaculum are from medial to lateral, same as that of the your superior extensor retinaculum. So it is tibialis anterior, extensor hallucis longus, followed by anterior tibial vessels and deep peroneal nerve, extensor digitorum longus and peroneus tertius. Medial to lateral. Okay, so these are the muscles which are passing. Excuse me. Next, you are able to see the peroneal retinacula. You have the superior and the inferior peroneal retinacula, which holds the tendon of peroneus longus and peroneus brevis. Superior peroneal retinacula extends from the lateral malleolus to the calcaneus, and deep to that you are able to see the peroneus longus and brevis, which is inside a common synovial sheath. Inferior peroneal retinacula, above it is attached to the peroneal trochlea and below it is attached to the peroneal tendons. Okay, that projection is actually called as the peroneal trochlea, and passing deep to is the peroneus longus and brevis muscle, but they are enclosed in a separate synovial sheath. In the inferior peroneal retinacula, both the muscles have their own synovial sheath because the tendons are diverging. The longus goes deep and gets attached to the base of the first toe and also to the medial cuneiform bone. So that is about the peroneal retinacula muscle. The next one you are able to see here is the flexor retinaculum. Posterior-medially, you are able to see the flexor retinaculum. So structures from the flexor compartment of the leg muscles, they are actually going to pass. The attachments is to the medial malleolus. Anteriorly it is attached to the medial malleolus and posteriorly to the posteromedial part of the calcaneum bone. So that is the extent. And you are able to see the structures passing again from medial to lateral. If you see, it is mainly tibialis posterior, followed by flexor digitorum longus. Then you have the posterior tibial vessel and the tibial nerve. Then finally you have the flexor hallucis longus. It is represented by a mnemonic Tom, Dick and Harry. Tom, Dick and Harry, or Tom, Dick, bloody for blood vessel, nervous for the nerve, Harry. Okay, so Tom stands for tibialis posterior, Dick stands for digitorum, flexor digitorum longus, and An, A for artery, posterior tibial vessels, N for nerve, tibial nerve, and flexor hallucis longus, H for Harry. So these are the structures passing from medial to lateral along the flexor retinaculum. So we have seen about the flexor retinaculum. So the retinacula around the foot are the inferior extensor retinaculum, peroneal retinaculum, which is again superior and inferior peroneal retinaculum. Then followed by that, what we have seen is the flexor retinaculum, retinacula around the foot. Okay, so in today's session, so kindly concentrate mainly on the Dorsalis Pedis artery, and then of course any one of the retinaculum can also be expected as a short note in the university examinations. Okay. So thank you very much for your patient listening. We will meet again in one more lecture.